What I wanted to focus on today is with ablation procedures, where this may be going, and while I'm going to be focusing on atrial fibrillation, some of what I have to say will apply to other problems we work with. And to put this in perspective, if we look at the kinds of ablation procedures we did in 2001, and this is just in our group, we were doing some AF ablations, but it was only 2% of our total volume. And now it's 30%. And I think that within the next couple years, it'll probably be closer to 60%. So this is something that has really taken off in recent years, and I think that it, not just here, but at other major academic centers and clinical centers, it will continue to be an important part of what we do. But as we look at the objectives, I think one of the problems we struggle with is we need to better understand the physiology and then base a strategy based on physiology and clinical trials that come out. Now we have to find ways of reducing complications and improve the technical aspects of ablation. And I'll try to cover a lot of these areas as we move on. Now, the first thing I think is, what is the target? Electrophysiologists have been focused initially on pulmonary vein isolations, and then the idea came about of modifying the substrate by ablating larger amounts of tissue, and this gets into the concept of left atrial mass, targeting areas of fragmented conduction, elimination of triggers, which is to some extent the pulmonary vein isolations, but there are other sources of triggers, and other efforts have focused on the autonomic nervous system. And if you look at some of the techniques and outcomes, they cross a broad range of approaches. The early work was related to focal ablation, and there was this circumferential approach, and not listed here, but is fragmented targets. And it's hard to know exactly what the success rate is for this. It's probably somewhere in the range of 60 to 70%, but I think as time goes on, we realize that there are more long-term recurrences, and we're working in ways of trying to reduce them. I thought the work that was published by the group here is interesting and how it fits into what we're doing. And this is where they looked at the effects of the mass of the atrium, the area required to sustain atrial fibrillation, and the effect of refractory period. And in essence, you have larger areas for wavelengths and circuits, and shorter refractory period, you're more prone to having atrial fibrillation. And if you think about what is done in the lab, this is a pre and post voltage maps that is one of the publications that I was looking at, and it's a nice example, I think, of here after the ablation procedure, you have these red zones that are low voltage areas, and these were just pulmonary vein isolations. You see there's a bit of a watershed effect here where you tend to get other areas that have low voltage after this. And a lot of groups will put in a superior line up here, or maybe even an inferior line there, and others. And typically when we do that, this whole area becomes sort of a low voltage zone. And I don't know for sure how well that holds up over time. I think some of that recovers, but it certainly drops during the course of the procedure. So what's the best strategy? The maze operation was developed in such a way that it really was the same operation for every patient. And I think that's the correct approach, because the substrate can evolve or change, and what you try to study on a given day may not be what somebody does the next day. In the early days of pulmonary vein isolations, people would sometimes just target one vein, and what happened over time is you realize that on another day, a different pulmonary vein was the source. You have this approach for an extensive substrate modification, or you could tailor it to a specific physiology. The problem is that the more aggressive you are, you get more potential complications, atrial flutter circuits develop, and so you're kind of damned if you do and damned if you don't. I think we're still trying to sort out exactly how aggressive we should be in these cases, and that has led to a tailored approach that Fred Barati's group has championed. I think in talking to Fred, his sense is that maybe the branding iron is too big in some cases, and that we could try to select this based more on the physiology of an individual patient. So, for example, in their series, what they did is first isolated the pulmonary veins, and if you look at this example, these are recordings from the pulmonary veins. It's the lasso catheter up in the pulmonary veins. And you'll notice how high the frequency is here as opposed to down in the coronary sinus. And this was a case where they thought this was a driver for atrial fibrillation, and they targeted that vein. Then you have this concept of targeting complex electrograms that are low frequency or low amplitude, high frequency electrograms, and this certainly has a different appearance than maybe over in this area. And this is similar to an experience I had just a few weeks ago. We did a pulmonary vein isolation on a patient who'd been in atrial fibrillation for 2 or 3 years, I think. And we had targeted a bunch of fragmented potentials, and she was still in atrial fibrillation. And then I was kind of curious to see whether the left atrial appendage might be a driver in this case. And we targeted this signal that had a frequency of about 190 milliseconds and just stopped. And I don't think that's coincidence. I think that this was a case where you modified the substrate. Maybe we've reduced the mass that can be involved in the arrhythmia. We've reduced triggers. And so you find these drivers and you knock them out, and people just convert to sinus rhythm. And the group from France actually is doing this in a stepwise manner and are able to stop about 80% of atrial fibrillation using this approach. It's sort of an all-day procedure, but it's been pretty effective. Now in Fred's work, you can see that they'll do a pulmonary vein isolation, and they find these other areas that may be fragmented activity or areas that they think are drivers, and ablate in those areas. And sometimes it takes a lot. This is a patient in which they have all these points scattered around. Fred thinks that if you do it in this way, because it's not linear, you're less likely to end up with atrial flutter further down the line. I think we're going to have to wait and see how that pans out over the long term, but that has been his experience so far. So in these patients with paroxysmal atrial fibrillation, he used inducibility as the endpoint of this procedure, and about 31% were not inducible in atrial fibrillation at the end of isolating the pulmonary veins. 69% were, so they ablated in other areas, the coronary sinus, the superior vena cava, areas in the left atrium. And out of that 69%, 27 ended up getting into the non-inducible group, and then 42% remained inducible. And when they look at their long-term outcomes, their finding is that the non-inducible ones have a lower recurrence rate. And not everybody else has reproduced that, but that's at least what they're finding. They've also done some interesting work with chronic atrial fibrillation. This is a summary of work that was done with Carlo Popponi. Carlo, as many of you know, has been a leader in this field over in Italy. Now, it's important to recognize that they have some significant exclusions. They didn't take people who were real old, 18 to 70, didn't have severely dilated left atria. Their ejection fractions had to be above 30%. They didn't have any mechanical valves. So there were some things that they took as precautions, but nonetheless, these are representative of a lot of patients with atrial fibrillation. And this is a little hard to interpret, but it has to do with their long-term success rates. It's not a survival curve. The reason the drug limb, which is the control, goes down so much is that they had a huge crossover from amiodarone to an ablation procedure. And so when they did that, they counted those people as failures that would never, so even though the intention to treat analysis, it was that they would never get over it. And that's probably valid. But anyway, that drops down to a very small percentage being controlled over the long term. And then ultimately they had about 75% of their patients who were off drugs, and as far as they could tell, free of arrhythmias over the long term. That's probably a little better than most other people are reporting, but some of it may be the way they selected the patients. I think probably a lot of people for chronic AF are more in the 40 to 50% range, but even that is a step forward over what we had in the past. The problem is that there are some significant complications associated with this procedure. procedure. It includes perforation, esophageal injuries, pulmonary vein thrombosis or stenosis, and embolism. And it's important to avoid the complications because once you get them, it's sometimes tough to know what to do about it. And that's particularly true for esophageal perforations. They happen very quickly. It can be lethal before you have a chance to even decide how to deal with it. Now, perforation is something that's been around for a long time. And this is a paper from Doug Packer and his group at the Mayo Clinic, in which they found that the perforation incidence was about 2.5%. And I think that's consistent with what most other people have experienced. And sometimes you go for a few years without a perforation, and suddenly you get a couple, and you just never let your guard down. Now, I think one of the things that may help us with this is some of the new technology. I'm not going to talk much about stereotaxis today, but this is a stereotaxis catheter, and it's very flexible. You can bend it around a lot, and when you push it up against the wall, it has a lot less force. It's enough to ablate tissue, but it doesn't have the same risk of perforation, in my opinion. And I think there's a fair amount of evidence to back that up. And as I'll get to, it may be significant for preventing problems with the esophagus. This is just a test that they did in which they took a standard catheter and pushed. You can see how far you can push a diaphragm versus with the stereotaxis catheter, because it's more flexible, this is the maximum deflection that they can get out of that. Now, the atrial esophageal fistulas are really, really dangerous. This is a publication from an Italian group. They reviewed a bunch of cases that they found in the literature, from what I could gather. The incidence is underreported, so we don't. The cases are underreported, so we don't know exactly what the incidence is. But they typically present about, on the average, 12 days after the procedure, and they can have fever, leukocytosis, seizures, signs of stroke, which has to do with air getting into the left atrium. And in their experience, all died. I had one that survived. It was a lady who developed a fistula in the esophagus. It did not connect to the atrium, so it wasn't really an atrial esophageal fistula. But the interesting thing is, we took her to surgery. When they opened her up and looked at it, there was no perforation in the left atrium. They couldn't see any defects that would do that. I think the problem is that because RF is a current, it can have some far-field effects of heating up tissue. And I think we drove up the temperature in the esophagus enough to cause damage. She did well in the long term, but it does bring to light the anatomy that we deal with, in which you can see the esophagus coming down. They take the heart out, but I point out that there's some autonomic nerves in the area, and I've seen problems with that too, that people will get gastric motility problems after an AF ablation, and I think what's happening is we're damaging some of those nerves. It generally gets better over a period of a couple of weeks, but there are cases where it hasn't. I've seen one of those, and it's been reported by other people. And then if you look at the anatomic relationships here, in some cases, a little bit more tissue between the esophagus and the left atrium. In others, it's pretty thin. And then if you look down below, that's a right pulmonary vein, left pulmonary vein. It's in the middle here. But here it's kind of sitting over next to the right pulmonary vein. And here it's over more towards the left pulmonary vein. That's exactly what we see when we do cases. We always do ours under anesthesia with a tube in the esophagus. And sometimes it's in the middle, but it can be on either side. It's invariably the way something you want to learn. And looking at these sections that they, again, you can see that there's not a lot of space. It's the left atrial cavity, atrium, esophagus here. Not a lot of tissue in between here. This was a case in which it was over closer to the right pulmonary vein. This is over closer to the left superior. And then the other thing you have to take into consideration is the thickness of the wall. And on the back wall of the left atrium, they've drawn the diagram here, it can be pretty thin there. If you look at these dimensions, they're typically less than 3 millimeters. So these are areas that as we apply force, first of all, we could potentially burn deep enough to reach the esophagus, and since this is very flexible, if you take a relatively stiff catheter and push too hard, you may not perforate, but you may push it up against the esophagus. So I think that if you just look at, say, a CT scan and say, well, there's the esophagus, that isn't necessarily good because, first of all, the esophagus moves a fair amount. And secondly, even if it doesn't, if you're pushing a catheter up next to it, I would think you're more likely to damage it with RF. And this is an example, actually. They were doing endoscopy during a procedure. They were looking at this. And this is the esophagus, of course. And here you'll see that this is kind of bulging here. Well, it's because somebody had a catheter in the left atrium and they were pushing on the back wall of the left atrium so it deforms the esophagus. You can imagine that that could increase the risk of an injury. Some people have used thermistors in the esophagus. We often have a thermistor in the esophagus that the anesthesiologists use. If the temperature goes up, I think it's wise to back off on the power. But the problem is the thermistor is not in contact with all the tissue in the esophagus. So failure to increase doesn't mean you're safe. So we've got some things we need to work on with that. They've also looked at it with echo. It's a little hard to see the esophagus with echo. This is it. And they actually gave the person a carbonated drink to make it fizz, and so they can see it better with echo. I don't know how practical that is on a widespread basis, but at any rate, that's something they were looking at. And what is a little disturbing to me is that when they looked at esophageal temperatures, they didn't correlate well with power. So when we're near the back wall and we're near the esophagus, we typically run the power down around 25 watts. But you can see that even there are times when you get an increase in temperature. And I think that's going to be related to the anatomic distance from the left atrium, or maybe the deflection or pressure of the catheter, and there may be other factors that enter into this. Pulmonary vein thrombosis and stenosis has been around for a long time. This is actually a figure that I had with Jim Cox when he was here, and there was a patient in the early days of ablation who came in with a big clot in one of the pulmonary veins over on the left. I think it was the left inferior, and the whole thing was just thrombosed off, and there was nothing to be done about it, really. Once it happens, you can't do very much about it. For people who get pulmonary vein stenosis, if it's just one pulmonary vein, the evidence is that they generally don't have severe symptoms. But as more pulmonary veins get involved, especially if they're on the same side, then people start getting a lot of trouble. And the risk of stenosis probably depends on technique. This is some work that Andrea Natale's group did years ago. And when they just used electroanatomic mapping here, they had a higher incidence of it. They tried a number of other approaches. We typically would shoot angiograms of the pulmonary veins, and that helps. They were also they were judging their power by whether or not they got bubbles when they were delivering RF, and that means you back off on the power. And using intracardiac echocardiography and looking for bubbles, they essentially eliminated that problem. I think as people have moved away from just trying to ablate right in the pulmonary veins into a broader region, that this is a lower risk. Thromboembolism remains a big risk, and this is a figure taken from a patient where they knew they had a high impedance on the catheter, and so they dragged it back and aspirated out of the sheath, and you can see these little flecks of junk here, which is charred tissue. And it's not uncommon for us, at least in the old days, with older catheter designs, to get impedance rise. And when you bring the catheter out, it had like barbecue on there, and that's not a good thing to have in the left atrium. Now, there are a variety of things that you can do to reduce that risk. One of the things they found was to keep the ACT up around 350 to 400, which is typically what we do. And then they were also looking at different types of catheters and things. But basically, I think all the groups in the country reached a consensus that in the old days we used to keep the ACTs down more in the 250 range. You just can't do that with this procedure. And You could also look at embolic events as a function of how they delivered energy, whether it was a catheter that had a temperature control on it, which is not optimal because it doesn't measure it accurately enough. They had problems with ultrasound, and the only way they were able to do it was by titrating the energy using this bubble information. Fred Marotti looked at the incidence of pulmonary vein, thromboembolism, and it was about 1% in his series. And the thing that's a little disturbing about it is that these patients don't necessarily have a lot of risk factors, and it can occur primarily in the first 2 weeks after the procedure. So is it that the thrombus forms during the procedure, or does it form afterwards, either in the appendage and then breaks free, or that it forms on tissue that's burned? And we don't know the answer to that right now. But what people are doing is anticoagulating more aggressively after the procedure, and we need to better understand the physiology of how these thrombi form. There's another report. In 20 patients, they did scans, cerebral scans, and in 2 of them, they picked up these, maybe it was 3, these little emboli that had occurred. They were asymptomatic, but it can't be good for the brain to be getting these things. There's some other evidence showing some micro material that can be detected by Doppler that goes up through the carotid during the procedure. So again, these are areas that we need to focus on to reduce those risks. So what new technologies may help? Well, I think that intracardiac ultrasound is being used by more groups. We have not used it a lot, but we are gearing up to do that. Irrigated catheters make a difference. I'm not real optimistic about balloon technologies, and I'll go through that. Some people are looking at integration with MRI to have better three-dimensional imaging with intracardiac catheters. There's the work that we have done and others have done with remote navigation. And I'll talk about non-invasive electrocardiographic imaging and perhaps the significance of that as we move forward. Well, intracardiac echo is great for helping with transeptal punctures. You get to see the pulmonary veins. You can see some of the effects of ablation, and you might be able to see the position of the esophagus, so that sometimes is hard to find. Now, this is some work that Natalie did, and it's hard to see in this image. But in essence, he was able to see some char building up at the tip of the catheter. There's the lead, and there's the char there. And there was another incidence in which there was a soft thrombus that formed at the near the end of the catheter. And these are, I think, are things that we really do see. And of course, if they break free, it depends on where they land. I mentioned that he likes to use echo, and other people have. Some are more interested in this than others, but this is the case where when the energy got too high, you start getting a lot of bubbles in the left atrium, and it has to do with, I guess, the steam release or tissue destruction. And if you back off from power, you can titrate the energy that way, and that's in essence how he does his ablations. Now, irrigated catheters, I think, have proved to be important. And they come in two designs. I think there's significant differences between them. One is a closed loop, so there's saline circulating inside the catheter, and the other, it's sort of a shower head configuration where the saline sprays out and bathes the tip of the catheter. And I think there's compelling evidence that this is a better design. Both will give reasonable depth in lesions. These just have to do with different times and powers that they had in there, but they both will give a decent sized lesion. The problem is that if you look at the bottom part is the electrode temperature. The top part is tissue temperature, and these are done in animal models so that they can actually make all these measurements. And what you see in the closed loop, the tissue temperature can get quite high, whereas it doesn't get so high with the open system. And that's a greater risk for charring or thrombus formation. And in fact, they saw that in this study, in which it's hard quite to see the image, and so they drew a cartoon of it, but there was a soft thrombus that formed around the tip of where the catheter had been. And that was with the closed loop system. You can get steam pops with either system. We certainly have seen that. It has to do with the heat building up to the point that some steam forms in the tissue and then it pops. Now, non-contact mapping is something people have been working on. The advantage, of course, is you can do 1D, but the analysis is very user-dependent. It has kind of a limited range, and it hasn't taken off in a major way, but it's based on a design in which you have a balloon that you can inflate. That's the MEA. And it has all these electro wires on the outer part, and they can do virtual electrograms with it and create potential maps. I wouldn't say it's taken off in a big way, and I think some of it has to do with the expense, some of it has to do with the difficulty of deploying it, and perhaps the other thing is that although it may turn out to be important to look at the physiology of atrial fibrillation, we do these ablations, they're more anatomically based right now, and so that this is perhaps had less of a role. What about balloons? Well, the idea here was that if you took a balloon-like device and put it in a pulmonary vein, that you could essentially do the whole pulmonary vein with one ablation. But they come in all sizes, that is, the pulmonary veins do. Sometimes they have a common pulmonary vein orifice, and they have these long muscular sleeves, and it's hard to position the balloon, and there's been a fair amount of collateral damage, so to speak. It usually ends up being phrenic nerve damage, is what that means. So it's not, been around for quite a while, but it hasn't really taken off. This is just a figure of a balloon. It's one of the older models that's out there. There are a lot of different energies that have been delivered through this. They've used lasers, they've used ultrasound, they've used cryo. But you can see that here's a case where the balloon is engaged near the os of the pulmonary vein. But the problem is the pulmonary veins come in all shapes and sizes. These are from scans that were done. And here, you can see these have kind of a common orifice. And you could potentially stick a balloon up in this area, but what we're doing with the catheters now is more ablating around this whole antral area. And they aren't all the same size. You get these kind of weird shapes that the pulmonary veins have where it's hard to figure out how to get a balloon that will really lodge itself and cover this whole area. So then you have the fact that they're not round, they're oval shaped. In fact, they're a lot more flattened sometimes than you see here. So as we look at how to design a balloon that would engage the whole antra of the pulmonary veins, it's not easy to design that. And I'm not optimistic that's going to take off too much. It's just another example. You can see here, we would probably try to isolate somewhere along this area. And this pulmonary vein has a completely different shape and orientation than the one that we here. So a one-size-fits-all balloon is just not going to work. These are attempts to try to quantitatively measure the dimensions of the pulmonary veins. And on the top is all the patients. At the bottom, they were comparing paroxysmal and chronic. There doesn't seem to be much of a difference that way. Some of these patients had common left ostia. That's not uncommon. They're much bigger. So it just keeps reinforcing what everybody's observed, that there's a lot of variability in this. Another technology that's interesting, I don't know exactly where it'll go. It's some work that the group at Hopkins has done in which they take a CT scan that's registered, an MRI scan that's registered, and they have markers on the body that they're very meticulous about, and then they go into the lab and they have a system that integrates this in such a way that these crosshairs show the position of the tip of the catheter, and so that you get remarkable anatomic detail. It's not a real-time MRI, but it is a real-time movement of the catheter within this MRI scan. And they're making some progress with this, and it's not to the point where it's ready to be used on a large scale, but it is something that could potentially be very useful in the future. And then there's the work that we've done with remote magnetic navigation, and I think the advantages there is it seems to be relatively precise. I think the risk of perforation is reduced. Once you learn to use the system, you can reduce the amount of fluoroscopy. In fact, you can pretty much maneuver the catheter around without needing fluoro once you kind of get the basic shells established with our three-dimensional images that we create, because you're just not going to perforate anything. It eliminates operator fatigue, and we've already been successful in integrating it with three-dimensional imaging systems. There are two things. There's one thing I left off of here that I should have put on. One is we need an irrigated catheter with it. I think the 4mm tip that's there is just not appropriate. The other thing is that I think any remote system, one of the difficulties is trying to judge contact. And one of the things we need help with is figuring out whether the catheter really is in firm contact with the tissue or whether it isn't, because there's no tactile feedback. And so that's an area that some groups are working on. There's some startup companies that have tried to develop some systems to deal with that. This is simply a picture of the lab that, in case you've never seen it, these large magnets swing in. They're operated by a computer control system that's inside this housing. And as they rotate, they create a common field vector. And then we can adjust that using a screen. This is some of their newer software in which it's integrated with the carto image, and so you can also superimpose it on x-rays, but the crux of it is you kind of grab hold of this little arrow with the mouse and just rotate it whichever direction you want. The field will change with you, or there are some keys on the keyboard that you can toggle back and forth. And it's getting a little slicker than it was even a year ago, so that's making good progress. There is competition out there. Hansen has developed a robotic navigation system. They have a deflectable sheet that has an electromechanical coupling to a workstation, and the advantage they have is that they can use anybody's catheter. You put up a catheter through there, so if there's a major breakthrough in catheter design, all they have to do is stick it up through their sheet. Now the problem is that there are actually two sheets. There's an 11.5 French sheet that goes up and is stabilized in the right atrium, and then inside that is a smaller sheet that actually does the deflections. It seems to respond well. The experience in humans is very limited, and there have been some perforations reported, even at very skilled centers. So I think the risk of perforation requires further study. My concern is that if you have a relatively rigid sheet, and then you're passing a catheter out through it, there's no room for the catheter to flex. And then if you don't have any tactile feedback to tell you you're up against tissue, it's not a small step to get perforation. So they're working on a feedback that will allow the operator to have a better sense of whether they're in contact with the wall. And if that comes along, that'll certainly be healthy competition for stereotaxis. Now, something that, of course, Joram Rudy and his group have been working on here, I think is really very interesting, and it's this concept of non-invasive electrocardiographic imaging, in which you could potentially use it to analyze the substrate, to study the physiology of atrial fibrillation, to design a strategy for treatment, or to eliminate and treat recurrences. And we are just kind of getting into this. We're getting some data on patients prospectively as they come in for their ablations for atrial fibrillation. And some of those will be people with paroxysmal atrial fibrillation who are in sinus rhythm at the time they come in. Others who are chronic atrial fibrillation, and the recordings would allow us to look at their circuits and maybe pick up drivers that are helping to sustain it. So it'll be interesting to see how that evolves. And we had, this is a picture of the system, I think it was first described in Nature Medicine, in which there's probably many of you have seen this because it's work that's been presented before, but there's this garment that, or electrodes that you wear as a vest. There's a CT scan, the thing is integrated and processed, and you can compare it, as we were doing here, with electrocardiographic recordings. And we had a patient that we called over and said, maybe you can give us a hand with this. It was a patient who had rheumatic heart disease. He had a percutaneous mitral valvuloplasty. had been done a few years ago. We did a pulmonary vein ablation procedure about 2 years ago, and she had very low voltage throughout the left atrium even before we did it. And I wasn't very optimistic that she would do well because I thought there was a lot of scarring. And oddly enough, she actually did do well for quite some time, and then she came back with more atrial fibrillation. We did another ablation procedure, and then she came back again. I don't think you can see it real well on this ECG, but when you looked at it, she didn't actually have atrial fibrillation. She had what looked like a focal atrial tachycardia. And so we called over, and Young came over and got the recordings, and Bill Kukulich is working with him to help coordinate this, and Young stayed up all night analyzing it. And he came to the conclusion that it was coming from left atrium. This represents the right superior and inferior pulmonary veins, left superior and inferior. And so it's medial to where the right superior is, in essence. This is a superior view. And I'll ask you to keep this in mind, because I'm going to show you a comparison of what we found in the lab using our system. Now this is showing the CT scan and how their image compared to that. And here are the right pulmonary veins, left atrium, left atrial appendage, right about in here. So it's going to be anterior as opposed to posterior. It's going to be fairly high, and it's not going to be very far from the right pulmonary vein. So this is an isochronal map from our lab when we were doing the study. In this case, this is the right superior pulmonary vein coming in here. So she had a middle branch, and it's the inferior one. This is an AP view. That's the left superior sticking up over there. This is a superior view. So you have the right pulmonary veins and the left pulmonary veins. We're looking at the roof. And where we had early activation was basically around where this white spot is. And we burned there and stopped it. And then in essence, we kind of moved the catheter around, try to encircle that area. And to my knowledge, she's never had a recurrence of it. She did, if we put her on isoproterenol, have, in essence, a multifocal atrial tachycardia. We tried to ablate that, but it was just too many sites that it came from. It was coming from the floor, though. And in any case, in the absence of isoproterenol, she was stayed in sinus rhythm. And she'd been up on the floor despite all sorts of medications. We could not keep her controlled. She had a heart rate of about 140 times a time. So I think that in putting together the images that we have here and where I would envision this was coming from, and what your group found, Norm, I think this correlates found very well. We also did a propagation map, and it shows it breaking out from that area. Now, what's also interesting is where can we go with this? And Young gave me a couple slides of some things that they're working on in which you can establish the geometry, make the recordings of what's going on. And this is some preliminary data that they have in which you can find, in this case, the activation kind of spread out from around the left inferior pulmonary vein. And there seem to be drivers in that area, and so you could look for drivers, or the other thing that is an interesting concept is to do Fourier transforms of the signals and look for this high frequency content, which in this case the highest frequency is here. There's more relatively high frequency tissue here. What does that mean for us? Well, is it that if we identify these kinds of areas in advance, if we take them into the lab, would these be areas that we would want to target in the future? And I think this is exciting data and might help us to better understand the physiology and the correct strategy we can take. So what's beyond the horizon? And nobody has a crystal ball. We were talking about this out in the hallway before we got started, and I think that there are a lot of times where people don't seem to see what's down the road. And, a little lack of insight there can get you in trouble. Another way of looking at it is that, you know, if you're kind of focused on one thing and not paying attention to what everybody else is doing, you can get left behind. And we see that from time to time. And every once in a while, there's some major conceptual breakthrough or technology that comes along, and people aren't paying too much attention to it. But it can really change the field as to what we could end up doing. And, you know, I think back on, in my career, we were at the forefront of doing arrhythmia surgery when the ablation technology came along, and we made that transition well, and have been involved with that. We've gotten involved with the pulmonary vein isolation procedures. We've worked with Ralph and his group and the surgical aspects of this. But is there something here that could just completely change the scenery? And I was thinking about an article that I'd come across. It's not that I'm getting into gynecology, but you know, they are doing this. They're taking images and using focused ultrasound to ablate tissue in the body, and they're doing it from the body surface. Well, you can imagine all sorts of problems with the heart. Here's a CT scan, I guess it was an MRI scan, which they use to determine the coordinates for that. Now, you know, a fibroid, uterine fibroid, isn't moving around. You know, it doesn't beat, it doesn't change probably much with respiration. So you would think it'd be a little harder to target, but we're learning to gate things. You have to deal with the lungs and the ribs and such in the chest that probably make it considerably more difficult. Imagine the esophagus is probably too close to the back atrial wall. You wouldn't be able to focus in there. But these are potentially surmountable issues. And I suppose that if you just sort of assume that nothing would ever happen differently, you could kind of be caught off guard in your field. And I think what it comes down to is that if you're locked into one approach or one concept and the field changes, pretty soon you're out to pasture. But if you change with it, you know, that's what makes everything exciting. And that's kind of the way I would view where this might be going. It probably is not going to happen in my professional career, but it might happen while some of the rest of you are active. Just have to see how it goes. So that's it. I think that if there's any discussion or other thoughts about this, I'm interested in hearing what you have to say. Yes.
Follow up on patients with atrial fibrillation ablated. What are you doing? There's a lot of stuff in the literature now talking about asymptomatic AF.
Oh yeah.
And it's not clear to me, first of all, even if you have asymptomatic AF, if it's, you know, a couple minutes, is that significant? If it's 30 seconds, is it significant?
To be honest, we don't have the infrastructure at our facility to answer that question. Now, what I can tell you is that places have invested a huge amount of effort into monitoring, and it's enough monitoring to drive most patients nuts. Is that there is a lot of asymptomatic atrial fibrillation. A lot of it is just a minute or two, but sometimes it can be 20 or 30 minutes. Where I see it is the people who have pacemakers. So modern pacemakers can tell you when patients are going in and out of atrial fibrillation, and we do see that. Now, a lot of times it's short. It's just seconds to a few minutes. And then you say, well, if you're going to track results, how do you count that? And Fred Marotti's been particularly outspoken about this. He doesn't think Kaplan-Meier's curves are appropriate for this necessarily, because sometimes a patient may go months and have an episode of atrial fibrillation, and maybe it lasts for a few minutes, and then they might go for a long time before they have another one. Well, if you just look at it from a Kaplan-Meier standpoint, that person's fatal. And yet, they didn't necessarily even feel it, and they're much better off than they used to be. So you kind of have different standards you could use. There are the people who are truly cured, the people who are better off, but not completely cured. They may not need to take medications, though the issue of anticoagulation is a touchy one in that group. But it's very hard to be certain that somebody's not actually having breakthroughs unless you just monitor them almost continuously, and it becomes very impractical. So, in essence, what we've done is what I'll typically do is have people use an event monitor if they're having any symptoms. You can get a Holter and just see if in that period of time they're having any episodes. But Holters only cover 24 or 48 hours, and so it really is kind of a false reassurance if they're not having something. And nobody has the answer.
So do you leave your patients unlimited?
Well, if they have chronic atrial fibrillation, I've generally just left them unlimited for at least a year before I make a decision about what to do about it. I'm not sure if we're really justified taking them on completely, but it may depend on what other risk factors they have. And for people with paroxysmal atrial fibrillation, many of them are taking aspirin to begin with. I'll typically anticoagulate them for 2 or 3 months and then put them back on aspirin, but I tell them they have to take aspirin the rest of the life. So that's probably the best we can do. Yes?
I'm just curious what other aspects which drive your skepticism about high-intensity focused ultrasound. We've been able to show in vitro at least in immobilized preparations that one can ablate AV node and focal ablations of ventricular tissue.
No, I don't know a lot about it, and so I didn't mean to imply that this was something that couldn't be dealt with. I just assumed that this was going to be a challenge for people, but I think the biggest issue is probably going to be gating. I mean, if you took something like the non-invasive electrocardiographic imaging, study the physiology, have some idea of what needs to be ablated, I can imagine a day where you focus some form of energy, whether it's ultrasound or maybe something else, to target that tissue. It's just to hold still for you. And with a beating heart, I mean, depends on how long it took to deliver the energy, but one way to get around the beating heart is just a big dose of adenosine. And, you might have 10 seconds of asystole, but,
Everybody hold their breath.
yeah, you hold the breath, give them adenosine. These are pretty quiet.
Lab all the time. No, he passes out, right?
So, I think this is conceptually feasible. And how long it takes to develop it remains to be seen. But it sounds like you're pretty well on the path.
We have to reestablish this collaboration with our collaborator from Case Western to develop technology. So we should just move to Michigan to be close.
Yeah. Any other thoughts? Catherine?
Is it known where the triggered activity arises from which muscle and which areas of, for example, around the pulmonary veins? Is it, what kind of
cells?
Cells, yeah, muscle cells.
Well, they're muscle fibers that extend well up into the pulmonary veins.
Mm-hmm.
And this has been known for a long time, but from an electrophysiology standpoint, nobody ever paid attention to it. But there's optical mapping studies that have been done in animals that correlate with triggers coming from those areas. And the rest of the group has some other insight. That's what I remember.
I think there's still a big debate whether it's focal activity, triggered activity, or micro reentry. It's not resolved yet. And some of the electrophysiology, as you know, is done by Stenosis and others. So there is some remodeling in those cells. The same as the atrial muscle.
My recollection.
So I think it's a question as to how much of it is really the trigger of it.
Wasn't the group at Case Western that had some nice optical studies showing reentry activity?
Jeffrey Olden showed some,
Jeff
showed some really
That's
good
right, definitely.
some studies where he showed reentry in very small areas.
Yeah.
So is the triggering thought to really be the initiation, or also?
Well, I think it's combinations of things, would be my guess. Is that, and I think when people get too rigid about exactly what the mechanism is for atrial fibrillation, probably multifactorial. I think there probably are high-frequency triggers. I think there probably is micro-reentry, probably macro-reentry. And it's how all those things play together that seems to determine Yes. Yes.
I was wondering if, in terms of navigation of the catheter with the magnets and stuff, when you're imaging it with under fluoroscopy, how would newer live 3D echo work in terms of imaging that kind of stuff?
Well, in terms of it interfering with the echo, you mean?
Yeah, I mean, could you see?
Yeah,
I just don't know if you can see the
I don't
catheter
think it
on
would be
live
a
3D.
problem in that we've done echoes in the room with the magnets around. You have to keep the equipment back a few feet from the magnets, and you have to have flat plate screens or they get distorted by the magnets. So unless there's something different about 3D echo as opposed to 2D echo, I don't think it would be an issue.
I mean, because it seems to have a lot of a pretty high resolution and
Yeah.
very nice three-dimensional images, and it might be as good as MRI or close to, or
Could
maybe
be,
good enough for your kind of purposes.
Yeah, Doug Packer and his group up at Mayo have been working on 3D echo for quite a while for this purpose, and it hasn't taken off, so I think there have to be some challenges in how it's processed. My sense is a lot of his images, which are beautiful, are highly processed and haven't gotten it down to the point where they can just do it on the fly.
I think the new Philips machine can do it on the fly, just live.
Live of the tissue, yeah. I mean, we've played around with the triplanar probe and whatnot, but when you're imaging a catheter, your echo beam it's a planar beam, and to encompass the whole catheter on the plane of the beam is difficult. So you end up usually truncating the catheter, sectioning it obliquely, so you can't see a nice little geometry moving in a three-dimensional space.
I see.
And
Could you
behind
just
the
see that?
catheter, there's lots of echoing or distortion. So it would require some kind of post-processing to remove
I
that.
see. In terms of, I'm thinking like in terms of seeing the edge and seeing if it's touching the wall. Just you don't have to see the whole thing. Just look at the edges. In terms of your tactile, also the tactile sensation.
Finding the tip of the catheter by echo is a little harder to do that.
Okay.
Any other comments? Yes,
One more question. What do you think about nerve ablation that's been going on, avoiding the ganglion?
Well, I didn't get into that
plexus?
here, although it's an interesting topic. The data I've seen on where the nerves seem to be attached into the left atrium is basically an area that's encompassed in a fairly wide circumferential ablation anyway, because they tend to be, based on some Jackson's work at least, sort of on that anterior part, especially of the right superior, and then extending down towards the right inferior, and then over on the left, same kind of thing, but especially down underneath the left inferior. And we pretty much encompass that in our ablation. We sometimes get fairly profound vagal influences while we're ablating, and how much of that is discomfort, even with people under anesthesia, or whether it's truly a direct effect on the nerves, I don't know.
Do you have any patients that you see prior to ablation that you suspect might have a vaguely mediated?
Oh, all the time.
I
Yeah.
mean, like if you got somebody that's PAF and they come into your normal sinus rhythm, can you put them into PAF by doing some sort of vagal
No,
maneuver?
you never do that. At least I've never seen that done or reported. But people often, for some people it's sympathetic, that when they exert
Right.
themselves they get it. But for others, it's some kind of a vagal stimulus. Now, a lot of times what they describe as drinking or eating will set it off. And that gets a little more complicated because not infrequently they'll talk about cold fluids. Well, the esophagus is right behind the left atrium. Maybe there's some irritation of cold fluids going down the esophagus and change the temperature. I don't know. Or maybe it's a bolus effect, that there's a mechanical distension of the esophagus. If you look at movies of the esophagus, Fred Murray had some interesting films that he came up with. It's like a snake, it kind of wiggles around when you swallow stuff. It's really quite dramatic. He put contrast in there, and then you can see this esophagus kind of, it might be pushing up against the atria in some people. So how much of that is a direct autonomic influence versus a mechanical influence? I think we don't know. You also have people who only get atrial fibrillation, in fact, when they
Right, well, they're probably true.
And that's probably vagal, although if you think about different sleep cycles, it's not just vagal. It goes on at night, REM sleep, and all the rest of it. There's some fairly wide sympathetic swings that go.
Okay, well,
All right,
thanks
thank
very
you.
much. It was great.
Yeah.